Well, thank you for the nice introduction, and thanks for the invitation. Very nice, and it's very nice to be here, obviously. Today I'm going to talk about the research I'm doing on substance use in people with mild and borderline intellectual disability. And I'm going to talk with you about why it's time to take that personal. The work is carried out together with colleagues from the Radboud University in the Netherlands, and I'm also affiliated to a service for people with intellectual disabilities. Well, we know from research from the last years that substance use in people with mild intellectual disability, that it's very prevalent. In our institution, it's up to 30% of the clients who according to DSM criteria are at risk for a substance use disorder. We know that they have more severe consequences. So for example, at school, at work, there's a high comorbidity with psychiatric problems, and they are obviously at higher risk for substance use disorder. When I started to work at Plurijn for about 10 years ago, it was striking that there is not really evidence-based substance use treatment for this group. Especially as they are in high need of it. And that's why we start thinking about what can we do from an evidence-based perspective to develop a treatment ourselves. From the literature, I knew that personalized targeted substance use interventions are really promising, especially from the point of view that they are a high risk group for substance use problems, and these personalized targeted interventions do work better for high-risk groups, and they also have a high need of level 4 personalization from the idea that substance use treatment doesn't fit for all, so we don't need a one-size-fits-all approach. Maybe some of you are familiar with the substance use risk profile scale and the theory of Patricia Conrad, and the scale is developed by Wojcik. And it stems from the idea that substance use treatment, if you tailor it to personality targeted characteristics, you can provide more personalized care for this group. And the SERPs consists of 4 personality profiles: impulsivity, sensation seeking, anxiety, sensitivity, and negative thinking. And well, these profiles can be used to tailor the intervention to the specific group. We started to develop a treatment program. We call it Take It Personal because of the personality profiles. And there are 3 main therapeutic principles in the program. Also hearing about it a lot today because they're evidence-based. So that's motivational interviewing to increase motivation to change, cognitive behavioral therapy, predominantly to learn self-control skills to target your substance use. And what's quite unique is that we use a daily diary method. There are a few main things we did to adjust the program to the intellectual disability. So we thought it was very important to do a repetition of topics.
Sorry.
Oh, is there something with a sound?
Yeah, that's okay. Okay. Speak directly into it.
Okay, hopefully this is better. Yeah. So we made adjustments to the intellectual disability. The first adjustment is repetition of topics. So every topic comes back in an A session and a B session. There's involvement of a confidant, so that can be someone from the family or the private environment of the client, but sometimes it's a professional caregiver who is really well familiar with the client, and he comes along to the sessions. And so in one of the sessions the confidant is present, and the other session the client is alone with the therapist. And also simplified language is of course very important. We use the daily diary method. And it's linked to diary methods used in cognitive behavioral therapy, but we do it with a cell phone app, and everybody who participates in Take It Personal uses this app and gets one survey prompt a day, usually somewhere at night, and they look back at the day before or the day they had a day, and they fill out a question whether they did use their primary substance today, and how many times they did, and there are some other questions about mood and other stuff. And it shows that this increases the awareness of the client about their own substance use, and it's also very important to, well, if they get it to the treatment session, they can talk about actual substance use in the previous days. We did also a study to check whether this method is feasible in people with ID, and we found that it is indeed feasible. So there was a high compliance rate of the daily questionnaires, and our conclusion is that science and clinical practice can and should benefit from this. And what is important is to tailor the items to the individual. So, for example, like Bobby just told, that some people think that beer is not alcohol, then you have to ask the good questions and use the words they use for their substance. I also think that these daily diary methods perfectly align with small data designs. And in our case, working from clinical practice, starting at helping individuals, we have to use more small data designs, like single case experimental designs. What the big advantage is that we can learn faster with less data. And let me get the points are. Yes, in this diagram you can see that this really matters if you have just like a cross-sectional survey at with what point in time you ask questions about substance use. And you can see that, well, the point of time measures is important for the line you get. And also we found that it's very important to capture life as it is lived by these clients, and not just large general questionnaires, which are more difficult to comprehend. We did an effectiveness study on our treatment program, Take It Personal. And we used a single case experimental design. I think I just can go through, yeah. So the design consists of a baseline phase in which the client didn't get to treatment yet. After that there's a treatment phase. The treatment has about 22 sessions, but you can see later on in the data that sometimes they really need more sessions to obtain the goals. And we did a post-treatment measurement of 1 month. All the measures were completed with the Daily Diary app, and we measured substance use and craving. These are the results of our, I have to mind to stay at the mic. And what we found is that overall in our 10 participants, we found a statistically significant decrease in daily substance use in 8 out of 10. And this is just an example of 3 of our participants. This is participant 2. As you can see from the pretty flat lines, so the dots are the measures of the daily substance use. So this is a candidate who used cannabis daily. At baseline, he smoked 1.5 or 2 joints a day. And during treatment, that really didn't change. Sometimes there was a day with more use and a day with less use. And this line is the mean or the average of the phase. And so you can see that there was no difference. But these are 2 clients in which, so 2 of 8 in which we found effects. And what we see over here is that we tested whether the mean decreased in each phase. And so in this client you see that at the beginning of the treatment, there was still a lot of cannabis use, but it decreased over time, and at the end of treatment, he completely stopped using cannabis. But you can also see on the timeline that it took a lot of time. So this client was in treatment for about 300 days. And similar results, but a little bit different pattern for client number 8. We also did a qualitative study and asked our participants what they think about the treatment. We also invited their confidence to talk with us and wrote a paper about it. Well, with regard to the effectiveness, one client said, well, I think without my therapist, I would still have been addicted, I think, and still using. Now this will be my 5th month clean. And an important part of the therapy is learning the self-control skills. And this client said, for example, taking something too, so he's referring to a friend who encourages him to use when they are in a club, for example. He said, well, then I already took it, but if they ask it now, I will immediately leave the situation and go home, and that helped me. So that's an example of a self-control skill, leaving the situation. And there's another client talking about his brother, who was his confidant, and he said, my brother did not know things about me that he does know now. In my opinion, if people participate and take it personal, they should bring a family member, success guaranteed. For me, he is still my confidant, and he will always be. So we concluded from these 2 studies that treatment effectiveness in substance use was visible in the majority of participants, and according to clients themselves, the program is helpful. We also conducted some studies on the mechanism of change. So the therapeutic principles, motivational interviewing and cognitive behavioral therapy were very important to us, and we would like to measure and see, examine, test whether it worked in clients with mild intellectual disability, because studies are lacking still on this topic. What we did is all clients in our study had sessions with motivational interviewing, and we would like to explore if motivational interviewing evokes change talk in people with mild intellectual disability. So change talk is a precursor of actual behavioral change, so it's important to evoke change talk. And how we did that, we had observational coding of recorded MI sessions, so there were voice recordings of all the sessions. They were completely coded, so every utterance the client and the therapist and the confidant did were coded, and then we analyzed whether therapist motivational interviewing techniques and client evoked change talk in clients. What we found was that clients are able to express change talk in their own words, and when the therapist uses ME consistent behaviors like reflective listening, affirmations, open questions, the change talk increased. And we also concluded that clients benefit from motivational interviewing if it's adapted to their cognitive needs. So you have to have a slower pace, use simple reflections, and use visual aids if necessary. And this provides a foundation for MI in this kind of treatment programs for people with intellectual disabilities. We also examined whether self-control skills were effectively applied by our clients. And that's important because craving is associated with substance use, so decreasing craving, or at least applying self-control skills to handle your craving, is very important, and that's also one of the big parts in the treatment program. So, for example, self-control skills are looking for alternatives, distraction, and saying no. And what we did is a study to explore whether substance use and craving decreased during treatment, and whether, so this is the second part, and whether the association between both decreased during treatment. And this is a small part of the results. So again, the two clients we saw before, participant 7 and participant 8. And for these two clients, we already saw that the treatment was effective in substance use. And now we also measured the daily diary measures for craving. And we divided the treatment phase into 2 phases. So in the first part of the treatment, it's mainly, well, you have to start up the treatment, doing motivational interviewing, and the real practice with those self-control skills takes part in the second part of treatment. And so we first tested whether craving decreased, and that was significantly the case in both of these clients. And we also tested whether the relationship between craving and substance use decreased over time. So that gives an indication if you're still craving for use, but you don't actually use, then you have to use your self-control skills. And that is also what, so this is the non-significant, so that is also what we found. So from intervention compared to baseline, and the second part of intervention compared to the first part, and then from post-treatment compared to treatment, in all those phases we found that the association between craving and substance use decreased, so people were able to use self-control skills. But not all of our clients. This is one of 6 clients who didn't, in who we didn't find any effects on the craving. And you can see, well, he didn't manage to reduce his substance use, but the craving kept high during treatment for all the whole period. And this is some preliminary work. We are still working on fine-tuning the analyses and writing up the paper. But for now, we see that 6 out of 10 clients were able to decrease their craving. And on group level, we found that the strong average same-day correlation between craving and substance use decreased in all subsequent phases. And yeah, this is, in our opinion, the first indication for the effectiveness of self-controls as a mechanism of change in this group of people with intellectual disabilities. This is one of our clients, Rainerio, and it's a still of a video because the video is in Dutch, of course. But I think he, in his own words, describes, without our instruction, what learning self-control skills meant to him. So he said, well, now I have options, you know. Stay away from drugs is a choice you make yourself. And I was somewhere in the back when they were filming him, and that made me really smiling and happy, because to have a client talking in their own words about the theoretical mechanisms, well, it was pretty satisfying to hear that. So that leads me to my final slides already. The take-home message for now is that I think that personalized treatment is very promising in substance use for people with mild intellectual disabilities, and I think this brings us to a new way for treatment in this group. And I also believe that we, in practice, need to use small data paradigms to provide, next to evidence of effectiveness, also insights into how treatment works. Because, yeah, a lot of questions go about, does it work for this group? And these insights we found in our research. leaves me at thanking my co-workers for doing this work together with me. And on my last slide, I have some references. If you like to read on, you can do it later. Thanks for your attention.